Question 1. Research into the regulatory landscape of radiation oncology in Japan reveals several key organizations and their respective mandates. Which of the following accurately describes the primary roles of the Ministry of Health, Labor and Welfare, MHLW, and the Japan Society of Radiation Oncology, JASTRO, in governing radiation oncology practices? Option A. JASTRO is the sole regulatory body for radiation oncology, responsible for all aspects of licensing and patient safety oversight, with the MHLW providing only financial support. Option B. The MHLW is responsible for setting national healthcare policy and approving medical devices, while JASTRO develops and disseminates clinical practice guidelines and promotes professional standards within radiation oncology. Option C. International radiation oncology guidelines are directly enforceable in Japan without specific endorsement from either the MHLW or JASTRO, and JASTRO primary function is research funding. Option D. The MHLW exclusively dictates all clinical treatment protocols for radiation oncology, and JASTRO role is limited to organizing annual scientific conferences. Correct answer is B. The MHLW is responsible for setting national healthcare policy and approving medical devices, while JASTRO develops and disseminates clinical practice guidelines and promotes professional standards within radiation oncology. Explanation. This scenario presents a professional challenge due to the critical need for accurate and compliant reporting of radiation oncology practices within the Japanese healthcare system. Adherence to the specific guidelines and oversight mechanisms established by the relevant Japanese regulatory bodies is paramount for patient safety, quality of care, and legal compliance. The challenge lies in discerning which entity is primarily responsible for setting and enforcing these standards in the context of radiation oncology. The correct approach involves recognizing the distinct roles of the Ministry of Health, Labor and Welfare, MHLW, and the Japan Society of Radiation Oncology, JASTRO. The MHLW, as the national governmental body, is responsible for establishing overarching healthcare regulations, including those pertaining to radiation safety and medical device approval. JASTRO, as a professional society, plays a crucial role in developing clinical guidelines, promoting best practices, and fostering professional development within the field of radiation oncology. Therefore, understanding the interplay between governmental regulation and professional society guidance is key. An incorrect approach would be to assume that a single entity, such as a general medical association or an international body, holds exclusive authority over radiation oncology regulations in Japan. This overlooks the specific legal and professional structures in place. Another incorrect approach would be to prioritize international guidelines without considering their formal adoption or adaptation by Japanese regulatory authorities. This could lead to non-compliance with domestic laws and standards. Focusing solely on technological advancements without considering the regulatory framework governing their implementation is also a failure, as innovation must occur within established safety and efficacy parameters. Professionals should employ a decision-making process that begins with identifying the specific regulatory jurisdiction, Japan. They must then consult the primary governmental sources for legal requirements, MHLW, and the authoritative professional society for clinical best practices and guidelines, JASTRO. Understanding the scope of each body's authority and how they interact is essential for ensuring all aspects of radiation oncology practice are compliant and of the highest standard. Question 2. Risk assessment procedures indicate that for patients undergoing external beam radiation therapy, EBIT, for thoracic malignancies, there is a potential for significant interfractional setup variations due to respiratory motion and changes in patient posture. According to the principles and guidelines relevant to the Japanese Society for Radiation Oncology certification exam, which of the following represents the most appropriate approach to ensure accurate patient positioning and treatment delivery? Option A. Implement daily image-guided radiation therapy (IGIT) with cone beam CT, CBCT, or similar imaging modalities to verify patient position immediately prior to each treatment fraction, adjusting the treatment couch as necessary based on image registration with the planning CT. Option B. Conduct initial patient positioning verification using a stereotactic body radiation therapy (SBRT) immobilization device at the start of the treatment course, assuming consistent positioning for subsequent fractions. Option C. Delegate the final verification of patient positioning to a radiation therapy technologist trainee under the indirect supervision of a senior technologist, without a mandatory review by a radiation oncologist or medical physicist. Option D. Rely on the patient's subjective report of comfort and absence of pain as the primary indicator that their positioning is correct for each treatment session. The correct answer is A. Implement daily image-guided radiation therapy, IGIT, with cone beam CT, CBCT, or similar imaging modalities to verify patient position immediately prior to each treatment fraction, adjusting the treatment couch as necessary based on image registration with the planning CT. Explanation. This scenario presents a professional challenge in ensuring patient safety and treatment efficacy during external beam radiation therapy, EBIT, by requiring a thorough understanding of the Japanese Society for Radiation Oncology, JASTRO, guidelines concerning patient positioning verification. The core of the challenge lies in balancing the need for precise dose delivery with the practicalities of daily patient setup, especially when dealing with potential anatomical variations or patient movement. Adherence to JASTRO standards is paramount to prevent under- or over-treatment, which can have significant clinical consequences. The correct approach represents best professional practice because it directly aligns with JASTRO emphasis on robust quality assurance and patient safety protocols. Specifically, it mandates the use of image-guided radiation therapy, IGIT, for verification of patient positioning prior to treatment delivery, especially in critical treatment sites or for patients with a higher risk of setup errors. This proactive verification minimizes geometric uncertainty, ensuring the radiation beam is accurately directed to the target volume while sparing organs at risk, thereby upholding the ethical obligation to provide competent and safe patient care as outlined by JASTRO certification standards. An incorrect approach that relies solely on patient self-reporting of comfort or absence of pain as a primary indicator of correct positioning fails to meet JASTRO's stringent requirements for objective verification. Patient perception can be subjective and may not accurately reflect subtle but clinically significant deviations in positioning. This approach neglects the fundamental principle of independent verification of treatment parameters, potentially leading to treatment errors and violating the duty of care. Another incorrect approach that involves performing positioning verification only at the initiation of the treatment course, without subsequent checks for significant anatomical changes or patient repositioning, is also professionally unacceptable. JASTRO guidelines implicitly require ongoing vigilance. Anatomical changes due to tumor shrinkage, weight loss, or patient repositioning during the treatment course can introduce significant geometric errors if not re-verified. This oversight can result in compromised treatment outcomes and a failure to adhere to established quality standards. Further incorrect approach that delegates the final verification of patient positioning to non-certified personnel without a clear protocol for independent review by a radiation oncologist or certified medical physicist is also problematic. While team collaboration is essential, JASTRO certification implies a level of expertise and accountability that necessitates oversight by qualified professionals for critical steps like treatment verification. This delegation, without appropriate checks and balances, risks introducing errors due to a lack of specialized knowledge or oversight, contravening the principles of responsible practice. The professional decision-making process for similar situations should involve a systematic evaluation of the JASTRO guidelines, the specific clinical context of the patient and treatment site, and the available technological resources. Professionals must prioritize objective verification methods, implement regular quality assurance checks, and ensure that all critical steps in the EBIT process are performed and overseen by appropriately qualified personnel, always with the patient's safety and the efficacy of treatment as the primary considerations. Question 3. Quality control measures reveal a higher than anticipated rate of acute radiation-induced dermatitis in a specific patient cohort treated with a particular external beam radiotherapy technique. Option A. Immediately adjust the treatment prescription for all future patients undergoing this technique without a detailed analysis of the current findings. Option B. Focus solely on advising patients to apply emollients more frequently without investigating the underlying technical or procedural causes. Option C. Initiate a comprehensive review involving radiation oncologists, medical physicists, and radiation therapists to analyze treatment planning parameters, dose delivery logs, patient positioning accuracy, and skin dose calculations for the affected cohort. Option D. Conclude that the observed dermatitis is an unavoidable consequence of the treatment technique, and no further investigation is warranted. The correct answer is C. Initiate a comprehensive review involving radiation oncologists, medical physicists, and radiation therapists to analyze treatment planning parameters, dose delivery logs, patient positioning accuracy, and skin dose calculations for the affected cohort. Explanation: scenario analysis. This scenario presents a professional challenge because it involves a discrepancy between expected and actual patient outcomes following a radiation therapy procedure. The challenge lies in identifying the root cause of this discrepancy, which could stem from various factors including treatment planning, delivery, patient factors, or even the quality control process itself. A thorough risk assessment is crucial to ensure patient safety and the integrity of the radiation oncology service. Correct approach analysis. The correct approach involves a systematic, multidisciplinary investigation to identify potential contributing factors to the observed adverse outcome. This aligns with the principles of continuous quality improvement and patient safety, mandated by regulatory bodies overseeing medical practices in Japan. By involving relevant personnel and reviewing all aspects of the treatment pathway, the team can accurately pinpoint the source of the risk and implement effective mitigation strategies. This proactive and comprehensive approach is essential for upholding the standards of radiation oncology care. Incorrect approaches analysis. One incorrect approach involves immediately attributing the outcome solely to a single factor without thorough investigation. This is professionally unacceptable, as it bypasses the necessary due diligence required for accurate risk identification and management. It fails to consider the complexity of radiation therapy and the potential for multiple contributing factors, leading to potentially ineffective or even harmful corrective actions. This approach risks overlooking critical issues and failing to protect future patients. Another incorrect approach is to dismiss the finding as an isolated incident without further scrutiny. This is a significant regulatory and ethical failure. Radiation oncology practice is governed by strict protocols for monitoring and reporting adverse events or deviations from expected outcomes. Ignoring such findings undermines the commitment to patient safety and the principles of evidence-based practice. It also neglects the opportunity to learn from the incident and improve future treatments. A third incorrect approach is to focus exclusively on the patient's individual response without considering systemic issues. While patient-specific factors can influence outcomes, a robust quality control system must also evaluate the processes and technologies involved. Failing to do so means that systemic flaws, which could affect numerous patients, may go unaddressed. This is a failure to adhere to the comprehensive risk management framework expected in radiation oncology. Professional reasoning. Professionals should approach such situations by initiating a formal incident review process. This process should involve gathering all relevant data, convening a team of experts, including radiation oncologists, medical physicists, dosimetrists, and radiation therapists, and systematically analyzing the treatment course from prescription to delivery and follow-up. The focus should be on identifying deviations from established protocols, potential equipment malfunctions, or planning errors. Based on the findings, a risk assessment should be performed to quantify the likelihood and severity of the identified risks, followed by the development and implementation of corrective and preventive actions. Continuous monitoring of the effectiveness of these actions is also paramount. Question 4. Which approach would be most appropriate for managing a patient with a locally advanced malignancy who has significant pre-existing cardiac disease and a history of radiation pneumonitis from prior thoracic radiotherapy when considering definitive radiation therapy? Option A. Implement a highly conformal radiation technique with reduced dose per fraction and close collaboration with cardiology and pulmonology for pre-treatment optimization and ongoing monitoring. Option B. Initiate treatment immediately with a standard external beam radiotherapy plan to avoid delays, deferring detailed assessment of comorbidities until after the initial treatment course. Option C. Proceed with standard fractionation and dose escalation to maximize tumor control, assuming the patient can tolerate the treatment. Option D. Administer palliative radiotherapy with a focus on symptom relief without attempting definitive tumor control due to the perceived high risk. The correct answer is A. Implement a highly conformal radiation technique with reduced dose per fraction and close collaboration with cardiology and pulmonology for pretreatment optimization and ongoing monitoring. Explanation. This scenario presents a common clinical challenge in radiation oncology, balancing the need for effective tumor control with the potential for treatment-related toxicity, particularly in a patient with pre-existing comorbidities that may increase their susceptibility to adverse effects. The professional challenge lies in individualizing treatment plans to optimize outcomes while adhering to established guidelines and ethical principles of patient care. Careful judgment is required to weigh the oncological benefits against the risks of radiation-induced damage, considering the patient's overall health status and potential for recovery. The correct approach represents best professional practice by prioritizing a comprehensive, multidisciplinary assessment and a shared decision-making process. This aligns with the ethical imperative to act in the patient's best interest and to respect their autonomy. Specifically, consulting with relevant specialists, e.g., medical oncology, palliative care, ensures that all aspects of the patient's condition are considered, leading to a more informed and holistic treatment strategy. Developing a personalized treatment plan that incorporates dose optimization, potentially exploring advanced techniques to spare critical organs, and establishing robust supportive care measures are all hallmarks of high-quality radiation oncology practice. This approach is further supported by the principles of evidence-based medicine and the continuous pursuit of minimizing harm while maximizing benefit. As expected of certified professionals, an incorrect approach that solely focuses on achieving the highest possible radiation dose without adequately considering the patient's comorbidities and potential for toxicity represents a failure to adhere to the principle of beneficence and non-maleficence. Such an approach risks causing undue harm and may lead to severe, irreversible side effects, potentially negating any oncological benefit and significantly impacting the patient's quality of life. This could be seen as a deviation from professional standards of care, which mandate individualized treatment and risk-benefit assessment. Another incorrect approach that prioritizes rapid treatment initiation without a thorough evaluation of the patient's overall health and potential for complications overlooks the importance of a comprehensive pretreatment workup. This can lead to suboptimal treatment planning and an increased risk of adverse events, as critical factors influencing treatment tolerance may have been missed. This approach fails to demonstrate due diligence and a commitment to patient safety. A third incorrect approach that relies solely on historical treatment protocols without considering the specific nuances of the current patient's case, including their comorbidities and potential for altered radiosensitivity, is also professionally unacceptable. While protocols provide valuable guidance, they are not a substitute for individualized clinical judgment. Failing to adapt treatment strategies to the unique characteristics of each patient can lead to either undertreatment or overtreatment, both of which are detrimental. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's oncological status, their overall health and functional status, potential treatment-related toxicities, and the patient's values and preferences. This should be followed by a multidisciplinary discussion to formulate a consensus on the optimal treatment strategy. Finally, a thorough discussion with the patient and their family, involving shared decision-making, is crucial to ensure that the chosen treatment plan is both clinically appropriate and aligned with the patient's goals of care. Question 5. The review process indicates that a research protocol involving low-dose radiation exposure to healthy volunteers for the purpose of studying subtle, long-term biological changes has been submitted. While the immediate risks are considered minimal and well understood, there is a theoretical possibility of unknown cumulative biological effects manifesting years or decades later, which cannot be fully quantified at present. The research team believes the potential for groundbreaking insights into radiation biology justifies proceeding with the study, even with this residual uncertainty regarding long-term outcomes. Considering the ethical obligations and regulatory framework of the Japanese Society for Radiation Oncology certification exam, what is the most appropriate course of action? Option A. Proceed with the study, emphasizing the minimal immediate risks and the significant potential research benefits, while briefly mentioning the theoretical possibility of long-term effects without dwelling on the uncertainties, as extensive discussion might deter participation. Option B. Halt the study immediately due to the presence of any unknown long-term biological risks, as the principle of do no harm strictly prohibits any exposure to potentially harmful, unquantifiable effects, regardless of potential benefits. Option C. Proceed with the study, focusing on the immediate, well-understood risks and benefits, and assume that any long-term effects, if they occur, will be manageable through future medical interventions, thus not requiring extensive upfront disclosure of theoretical uncertainties. Option D. Proceed with the study after ensuring a comprehensive informed consent process that clearly articulates the theoretical possibility of unknown long-term biological effects, the limitations in current scientific understanding of these effects, and the potential benefits and risks, allowing participants to make a fully autonomous decision. The correct answer is D. Proceed with the study after ensuring a comprehensive informed consent process that clearly articulates the theoretical possibility of unknown long-term biological effects, the limitations in current scientific understanding of these effects, and the potential benefits and risks, allowing participants to make a fully autonomous decision. Explanation. This scenario presents an ethical dilemma rooted in the principle of beneficence versus non-maleficence, specifically concerning the long-term biological effects of radiation on human tissue in a research context. The challenge lies in balancing the potential for future medical advancements derived from research data against the immediate ethical obligation to protect research participants from any avoidable harm, even if that harm is theoretical or probabilistic. The Japanese Society for Radiation Oncology Certification, exam, emphasizes adherence to ethical guidelines and regulatory frameworks governing radiation use, particularly in research. The correct approach prioritizes the informed consent process and the minimization of risk, aligning with the fundamental ethical principles of research involving human subjects and the specific guidelines of the Japanese Society for Radiation Oncology. It acknowledges the uncertainty of long-term effects and ensures participants are fully apprised of these potential risks, allowing them to make a truly autonomous decision. This approach upholds the principle of do no harm by not exposing participants to risks that are not clearly understood or adequately mitigated, and it respects participant autonomy by providing comprehensive information. An incorrect approach that proceeds without fully disclosing the potential for unknown long-term biological effects fails to uphold the principle of informed consent. This is a direct violation of ethical research conduct, as participants cannot make a truly informed decision if critical information about potential risks is withheld or downplayed. Such an approach could lead to unforeseen health consequences for participants, violating the principle of non-maleficence. Furthermore, it disregards the regulatory framework that mandates transparency and participant protection in research, potentially leading to ethical breaches and loss of public trust in research. Another incorrect approach that prioritizes the potential research benefits over participant well-being demonstrates a flawed ethical reasoning. While research benefits are important, they must never come at the expense of participant safety and autonomy. This approach prioritizes a utilitarian outcome without adequately considering the individual rights and well-being of the research subjects, which is ethically unacceptable. It also fails to acknowledge the inherent uncertainties in predicting long-term biological effects, making the prioritization of potential benefits over known or potential risks a premature and ethically unsound judgment. The professional decision-making process for similar situations should involve a thorough risk-benefit analysis, with a strong emphasis on participant safety and autonomy. This includes consulting relevant ethical guidelines and regulations, seeking input from an institutional review board or ethics committee, and ensuring that the informed consent process is robust, clear, and comprehensive. Professionals must be prepared to halt or modify research if unforeseen risks emerge or if participant understanding is compromised. Transparency, continuous ethical reflection, and a commitment to participant welfare are paramount. Question 6. The analysis reveals a 65-year-old male patient diagnosed with locally advanced squamous cell carcinoma of the oropharynx, staged as T3N2BM0. The patient has a history of well-controlled hypertension and type 2 diabetes mellitus, both managed with oral medications. He is a former smoker, having quit 10 years ago. Considering the established indications for radiation therapy as outlined by the Japanese Society for Radiation Oncology, which of the following represents the most appropriate initial management decision regarding the role of radiation therapy? Option A. Radiation therapy is indicated as part of a definitive treatment strategy, potentially combined with chemotherapy, given the locally advanced stage and absence of distant metastases, with careful consideration of managing his comorbidities. Option B. Radiation therapy is not indicated as the primary treatment modality for this stage of oropharyngeal cancer, and surgical resection should be pursued exclusively. Option C. Radiation therapy should be initiated immediately as a standalone treatment, without further evaluation of chemotherapy or surgical options. Option D. Radiation therapy should be deferred due to the patient's age and comorbidities, and the focus should be solely on palliative care. The correct answer is A. Radiation therapy is indicated as part of a definitive treatment strategy, potentially combined with chemotherapy, given the locally advanced stage and absence of distant metastases, with careful consideration of managing his comorbidities. Explanation: this scenario presents a professionally challenging situation due to the nuanced interpretation of indications for radiation therapy in a patient with a complex medical history and a potentially curable malignancy. The challenge lies in balancing the established guidelines for radiation oncology with the individual patient's specific circumstances, including comorbidities and potential treatment toxicities, all within the framework of the Japanese Society for Radiation Oncology, JASTRO, guidelines. Careful judgment is required to determine the optimal treatment strategy that maximizes therapeutic benefit while minimizing harm, adhering to the principles of evidence-based medicine and patient-centered care, as espoused by JASTRO. The correct approach represents best professional practice because it prioritizes a comprehensive, multidisciplinary evaluation and adherence to established JASTRO indications for radiation therapy. This involves a thorough assessment of the patient's disease stage, histology, and overall health status, followed by a discussion of treatment options, including the role and potential benefits of radiation therapy, in the context of JASTRO recommendations for similar clinical presentations. This approach ensures that treatment decisions are grounded in scientific evidence and align with the standards of care recognized by the Japanese Society for Radiation Oncology, thereby upholding professional responsibility and ethical obligations to the patient. An incorrect approach would be to proceed with radiation therapy without a clear indication as defined by JASTRO guidelines, or to dismiss radiation therapy solely based on a single comorbidity without a thorough risk-benefit analysis. Proceeding without a clear indication, as per JASTRO, would represent a failure to adhere to the established standards of practice and could lead to unnecessary treatment-related morbidity without a commensurate oncologic benefit, violating the principle of beneficence. Dismissing radiation therapy without a comprehensive evaluation of its potential role and the patient's specific risk profile, even in the presence of comorbidities, could lead to suboptimal oncologic outcomes and a failure to provide the best available treatment, thus contravening the principle of non-maleficence and potentially JASTRO guidance on managing complex cases. Furthermore, failing to involve a multidisciplinary team in the decision-making process for complex cases, as often recommended by professional societies like JASTRO, would be a significant professional and ethical lapse. The professional reasoning process for similar situations should involve a systematic approach. First, meticulously review the patient's diagnosis, staging, and relevant imaging. Second, consult the most current JASTRO guidelines and relevant peer-reviewed literature to identify established indications for radiation therapy for the specific malignancy and stage. Third, conduct a thorough assessment of the patient's comorbidities and overall performance status, evaluating how these factors might influence treatment tolerance and outcomes. Fourth, engage in a detailed discussion with the patient and their family about the potential benefits, risks, and alternatives to radiation therapy, ensuring informed consent. Finally, if the case is complex or falls outside clear-cut guidelines, seek consultation with a multidisciplinary team, including medical oncologists, surgeons, and radiation oncologists, to arrive at the most appropriate and evidence-based treatment plan consistent with JASTRO principles. Question 7. Governance review demonstrates that a patient with advanced metastatic disease is experiencing significant bone pain and dyspnea, impacting their quality of life. The radiation oncology team is considering palliative radiation therapy. Which of the following approaches best aligns with the principles of palliative care and the regulatory framework for radiation oncology in Japan, as guided by the Japanese Society for Radiation Oncology, JSTRO. Option A. Refer the patient exclusively to the palliative care team for all symptom management, with the radiation oncology team only providing radiation if specifically requested by the palliative care team for tumor debulking. Option B. Proceed with palliative radiation therapy based on the radiation oncologist's clinical judgment alone, assuming that symptom relief will be a natural consequence of tumor control, and inform the patient of the planned treatment. Option C. Convene a multidisciplinary team meeting involving the radiation oncologist, palliative care specialist, and nursing staff to discuss the patient's symptom burden, prognosis, and potential benefits and burdens of palliative radiation, followed by a shared decision-making discussion with the patient and family. Option D. Initiate a high-dose palliative radiation course targeting the painful bone metastases and dyspnea-causing lesions, with a focus on tumor shrinkage as the primary objective, and inform the patient of the treatment plan. Correct answer is D. Initiate a high-dose palliative radiation course targeting the painful bone metastases and dyspnea-causing lesions, with a focus on tumor shrinkage as the primary objective, and inform the patient of the treatment plan. Explanation. Scenario analysis. This scenario presents a common challenge in palliative radiation oncology, balancing aggressive symptom control with the patient's overall prognosis and treatment goals. The professional challenge lies in accurately assessing the patient's needs, communicating effectively with both the patient and their family, and adhering to the ethical and regulatory guidelines governing palliative care in Japan. The need for careful judgment arises from the potential for differing interpretations of best interest, and the importance of respecting patient autonomy while ensuring adequate symptom relief. Correct approach analysis. The correct approach emphasizes a multidisciplinary team discussion, including the radiation oncologist, palliative care specialist, and nursing staff, to formulate a comprehensive plan. This aligns with the principles of patient-centered care and the Japanese Society for Radiation Oncology, JSTRO, guidelines, which advocate for integrated care models. Specifically, the JSTRO framework promotes collaborative decision-making to ensure that treatment plans are tailored to individual patient needs, including symptom management, and are communicated transparently. This approach respects patient autonomy by involving them in the decision-making process and ensures that all relevant expertise is leveraged for optimal outcomes. Incorrect approaches analysis. One incorrect approach involves solely focusing on the radiation oncologist's assessment of the tumor's response, without adequately considering the patient's subjective experience of pain and other symptoms. This fails to meet the JSTRO emphasis on holistic patient care and symptom management as a primary goal in palliative settings. It risks undertreating pain and distress, which is ethically problematic and contrary to the principles of compassionate care. Another incorrect approach is to proceed with a high-dose palliative radiation regimen without a thorough discussion with the patient and family about the potential benefits and burdens, including the impact on quality of life and the possibility of increased side effects. This violates the principle of informed consent and patient autonomy, which are fundamental in Japanese medical practice and are implicitly supported by JSTRO ethical considerations for patient care. A third incorrect approach is to defer all palliative care decisions to the palliative care team without active input from the radiation oncologist regarding the specific role and potential benefits of radiation in symptom management. While collaboration is key, the radiation oncologist's expertise in predicting and managing radiation-induced side effects and their potential to alleviate specific symptoms, e.g., bone pain from metastases, is crucial for a well-rounded palliative plan. This approach could lead to suboptimal symptom control if radiation's unique palliative potential is not fully explored and integrated. Professional reasoning. Professionals should adopt a systematic approach that begins with a thorough assessment of the patient's symptoms and their impact on quality of life. This should be followed by open and honest communication with the patient and their family about treatment goals, including symptom relief and preservation of function. A multidisciplinary team meeting is essential to synthesize information and develop a consensus plan that respects patient preferences and aligns with JSTRO guidelines. Continuous reassessment of symptom burden and treatment effectiveness is paramount, with adjustments made as needed to ensure optimal palliative care. Question 8. The assessment process reveals a newly diagnosed case of lung adenocarcinoma with specific molecular markers identified through genomic sequencing. The radiation oncologist is tasked with determining the most appropriate treatment strategy, considering both the histological subtype and the identified molecular alterations. Which of the following approaches best reflects the current understanding of tumor biology and classification in guiding radiation oncology treatment decisions according to JSTRO principles? Option A. Classify the tumor based solely on its histological subtype, e.g., acinar, papillary, and stage, proceeding with standard treatment protocols for that category. Option B. Classify the tumor based on the patient's symptoms and overall health status, prioritizing palliative radiation if the patient expresses significant discomfort. Option C. Classify the tumor by integrating its histological subtype, stage, and the identified molecular markers, e.g., EGFR mutation status, ALK rearrangement, to refine prognosis and inform treatment selection. Option D. Classify the tumor using a historical classification system that was prevalent 10 years ago, as it provides a stable and well-understood framework. The correct answer is A. Classify the tumor based solely on its histological subtype, e.g., acinar, papillary, and stage, proceeding with standard treatment protocols for that category. Explanation: scenario analysis. This scenario is professionally challenging because it requires the radiation oncologist to integrate complex tumor biology information with established classification systems, directly impacting treatment planning and prognosis. Misinterpreting or misapplying these concepts can lead to suboptimal or even harmful patient care, highlighting the critical need for precise knowledge and application of current oncological understanding within the Japanese Society for Radiation Oncology (JSTRO) framework. Correct approach analysis. The correct approach involves accurately classifying the tumor based on its molecular and histological characteristics as defined by current JSTRO guidelines and relevant international consensus. This ensures that the treatment strategy is tailored to the specific biological behavior of the tumor, maximizing efficacy and minimizing toxicity. Adherence to these classifications is paramount for standardized care and effective communication among multidisciplinary teams, aligning with the JSTRO commitment to evidence-based radiation oncology practice. Incorrect approaches analysis. One incorrect approach would be to rely solely on gross anatomical staging without considering the underlying tumor biology. This fails to acknowledge that tumors with similar anatomical presentation can have vastly different prognoses and treatment responses due to genetic mutations or cellular differentiation, violating the principle of personalized medicine and potentially leading to under- or overtreatment. Another incorrect approach is to apply outdated classification systems that do not incorporate recent advancements in molecular pathology. This would result in a mischaracterization of the tumor's aggressiveness and potential for recurrence, leading to inappropriate treatment decisions that are not aligned with current best practices as expected by the JSTRO. A further incorrect approach would be to prioritize patient preference over established biological classification when making treatment decisions. While patient autonomy is crucial, it must be exercised within the bounds of medically sound and evidence-based recommendations derived from accurate tumor classification. Ignoring biological realities based solely on preference can lead to ineffective treatment and poorer outcomes, contravening the ethical and professional obligations of a radiation oncologist. Professional reasoning. Professionals should approach such situations by first meticulously reviewing all available diagnostic data, including histopathology, molecular profiling, and imaging. They must then consult the most current JSTRO guidelines and relevant peer-reviewed literature to accurately classify the tumor. This classification should then inform the selection of appropriate radiation techniques, dose fractionation, and potential combination therapies, always in consultation with the multidisciplinary team and with open communication with the patient regarding the rationale for the proposed treatment plan. Question 9. During the evaluation of a patient with a small peripherally located lung nodule adjacent to the spinal cord, requiring stereotactic body radiation therapy, SBRT, which of the following approaches best reflects adherence to established Japanese Society for Radiation Oncology, JASTRO, guidelines for SRS/SBRT? Option A. proceed with a conventional fractionated radiation therapy plan for the lung nodule, as SBRT is considered too risky for lesions in close proximity to the spinal cord. Option B. Implement an SBRT plan without specific attention to spinal cord dose constraints, assuming that the small size of the lesion will inherently limit radiation exposure to the spinal cord. Option C. Develop an SBRT plan that achieves the prescribed biologically effective dose to the target, while strictly adhering to the spinal cord dose constraints outlined in JASTRO guidelines, potentially utilizing advanced planning techniques to achieve steep dose falloff. Option D. Prioritize achieving a lower dose to the spinal cord by significantly reducing the prescribed dose to the lung nodule, even if it compromises tumor control. The correct answer is C. Develop an SBRT plan that achieves the prescribed biologically effective dose to the target while strictly adhering to the spinal cord dose constraints outlined in JASTRO guidelines, potentially utilizing advanced planning techniques to achieve steep dose falloff. Explanation. This scenario presents a common challenge in stereotactic radiosurgery, SRS, and stereotactic body radiation therapy, SBRT, where the optimal treatment strategy requires balancing efficacy with potential toxicity, particularly when dealing with a lesion adjacent to critical structures. The professional challenge lies in interpreting imaging findings, understanding dose volume constraints, and applying established guidelines to personalized treatment. Careful judgment is required to select a plan that maximizes tumor control while minimizing the risk of unacceptable side effects, adhering to the principles of radiation oncology as outlined by the Japanese Society for Radiation Oncology, JASTRO guidelines. The correct approach involves a comprehensive review of all available imaging modalities, including MRI with contrast and potentially PET-CT, to accurately delineate the target volume and surrounding organs at risk or. This is followed by a detailed dose volume histogram, DVH, analysis to ensure that the prescribed dose to the target is achievable within acceptable OAR constraints, as defined by JASTRO recommendations for SRS/SBRT. The decision to proceed with SBRT, considering the proximity to the spinal cord, necessitates a meticulous treatment planning process that prioritizes dose escalation to the tumor while strictly adhering to dose limits for the spinal cord to prevent radiation-induced myelopathy. This aligns with the JASTRO emphasis on evidence-based practice and patient safety in advanced radiation techniques. An incorrect approach would be to proceed with a standard fractionation scheme without considering the specific dose constraints for SRS/SBRT, especially when treating near-critical structures like the spinal cord. This fails to acknowledge the unique radiobiological principles and dose escalation potential of SRS/SBRT, increasing the risk of toxicity. Another incorrect approach would be to compromise the prescribed dose to the tumor significantly to meet OAR constraints without exploring alternative planning techniques or dose distributions, potentially sacrificing tumor control. This deviates from the goal of delivering a biologically effective dose to the target. Furthermore, neglecting to consult relevant JASTRO guidelines for SRS/SBRT, particularly concerning dose limits for OAR such as the spinal cord, represents a failure to adhere to established professional standards and could lead to suboptimal or unsafe treatment. The professional decision-making process should involve a systematic evaluation of the patient's clinical presentation, imaging characteristics of the lesion, and the precise anatomical relationship to OARs. This should be followed by rigorous treatment planning, incorporating advanced techniques to achieve steep dose gradients. A multidisciplinary discussion, including radiation oncologists, medical physicists, and radiation therapists, is crucial to review the plan and ensure it meets both efficacy and safety criteria according to JASTRO guidelines. Question 10. The control framework reveals that early radiation therapy utilized orthovoltage units, which delivered radiation primarily from sources with energies up to 300 kV. Considering the historical evolution of radiation oncology and its impact on patient care, which of the following represents the most appropriate understanding of orthovoltage therapy in the context of modern Japanese Society for Radiation Oncology, JASTRO certification standards? Option A. Orthovoltage therapy, despite its historical significance, is largely superseded by modern megavoltage linear accelerators due to limitations in dose penetration, skin sparing, and treatment planning precision, making it unsuitable for current therapeutic applications. Option B. Orthovoltage therapy remains a viable option for certain superficial tumors due to its lower equipment cost and simpler operation, and should be considered alongside modern techniques. Option C. The historical development of orthovoltage therapy highlights the importance of radiation dose escalation, and efforts should be made to adapt these older machines for higher energy outputs. Option D. The principles of orthovoltage therapy are fundamental to understanding the basic physics of radiation, and its techniques should be taught as a primary method for all radiation oncology trainees. The correct answer is A. Orthovoltage therapy, despite its historical significance, is largely superseded by modern megavoltage linear accelerators due to limitations in dose penetration, skin sparing, and treatment planning precision, making it unsuitable for current therapeutic applications. Explanation. The control framework reveals the historical development of radiation oncology techniques and their impact on patient care. This scenario presents a challenge in understanding how past innovations, while groundbreaking, may not align with current best practices or regulatory expectations for patient safety and efficacy. Professionals must exercise careful judgment to distinguish between historical significance and contemporary clinical relevance. The correct approach involves recognizing that, while early techniques like the use of orthovoltage units were foundational, their limitations in terms of dose distribution and skin sparing make them largely obsolete for modern therapeutic radiation oncology. Best professional practice dictates adherence to current guidelines and technological advancements that prioritize precise dose delivery, minimize collateral damage to healthy tissues, and optimize treatment outcomes, as mandated by the evolving standards of care within the Japanese Society for Radiation Oncology (JSTRO) framework. An incorrect approach would be to advocate for the reintroduction or continued reliance on orthovoltage therapy for routine clinical use. This fails to acknowledge the significant advancements in linear accelerators and sophisticated treatment planning systems that offer superior dose conformality and patient safety. Such an approach would represent a failure to comply with contemporary JSTRO guidelines and potentially violate ethical principles of beneficence and non-maleficence by exposing patients to suboptimal and potentially more harmful treatment modalities. Another incorrect approach would be to dismiss the historical context entirely, focusing solely on the most recent technologies without understanding the evolutionary path that led to them. This overlooks the valuable lessons learned from earlier techniques regarding radiation physics, radiobiology, and clinical outcomes, which inform current research and development. While not directly violating a specific regulation, it demonstrates a lack of comprehensive professional knowledge. A further incorrect approach might involve selectively applying historical knowledge without considering the full spectrum of evidence and established protocols. This could lead to an unbalanced perspective, potentially favoring older, less effective methods due to a superficial understanding of their historical impact. The professional decision-making process for similar situations should involve a thorough review of historical developments in radiation oncology, understanding their scientific underpinnings and clinical outcomes. This historical perspective should then be critically evaluated against current JSTRO guidelines, evidence-based medicine, and technological capabilities to determine the most appropriate and safe treatment strategies for contemporary patient care. Professionals must continuously engage in lifelong learning to stay abreast of advancements and their implications for practice. Question 11. System analysis indicates that a radiation oncologist is reviewing preliminary cell survival curve data from a phase Roman II clinical trial investigating a novel fractionation schedule for a specific cancer type. The observed curves for the experimental arm show a significantly shallower slope in the high-dose region compared to historical data for standard fractionation, suggesting potentially altered cellular radiosensitivity or repair kinetics. The oncologist must decide on the next steps regarding patient management and further data interpretation. Which of the following actions best aligns with the principles of responsible clinical research and radiobiological understanding, as expected within the framework of the Japanese Society for Radiation Oncology certification exam? Option A. Initiate a detailed discussion with the principal investigator and the study's radiobiology consultant to collaboratively analyze the survival curve data, explore potential biological explanations for the observed differences, and jointly determine the most appropriate course of action, which may include protocol review or further in vitro studies, while ensuring patient safety remains paramount. Option B. Inform the ethics committee of a potential protocol deviation and request permission to unilaterally modify the treatment parameters for individual patients based on their perceived response to the radiation, as indicated by the survival curve trends. Option C. Conclude that the observed survival curve deviations are likely experimental noise and proceed with the trial as planned, focusing solely on meeting the predefined statistical endpoints without further investigation into the radiobiological implications. Option D. Immediately adjust the treatment fractionation for all patients in the experimental arm to a more conventional schedule, assuming the observed survival curves indicate an unexpected and potentially detrimental radiobiological effect that could compromise treatment efficacy. The correct answer is A. Initiate a detailed discussion with the principal investigator and the study's radiobiology consultant to collaboratively analyze the survival curve data, explore potential biological explanations for the observed differences, and jointly determine the most appropriate course of action, which may include protocol review or further in vitro studies, while ensuring patient safety remains paramount. Explanation: scenario analysis. This scenario presents a professional challenge for a radiation oncologist involved in a clinical trial. The challenge lies in interpreting complex radiobiological data, specifically cell survival curves, in the context of a novel treatment regimen. The oncologist must balance the need to adhere to the strict protocols of the clinical trial, which are designed to generate reliable data for future patient care and regulatory approval, with the ethical imperative to ensure the safety and well-being of the trial participants. Misinterpreting the radiobiological implications of the observed survival curves could lead to inappropriate treatment adjustments, potentially compromising efficacy or increasing toxicity, and thus violating the principles of good clinical practice and research integrity. Correct approach analysis. The correct approach involves a thorough review of the cell survival curve data, considering the known radiobiological principles of the specific radiation modality and fractionation schedule used in the trial. This includes understanding the concepts of D0, N, and the shoulder region, and how they relate to cell kill and the potential for sublethal damage repair. The oncologist should consult with the principal investigator and the study's radiobiology expert to interpret the findings in the context of the trial's hypothesis and the expected biological response. If the observed curves deviate significantly from predictions or suggest unexpected radioresistance or hypersensitivity, a collaborative decision should be made regarding potential protocol amendments or further investigation, always prioritizing patient safety and data integrity, as mandated by the Japanese Society for Radiation Oncology, JSTRO Guidelines for Clinical Research. This approach upholds the ethical obligation to conduct research responsibly and to contribute valid scientific knowledge. Incorrect approaches analysis. One incorrect approach would be to disregard the observed cell survival curve data as merely an artifact of the experimental setup, or to assume it aligns with historical data without critical evaluation. This failure to engage with the specific radiobiological findings of the trial represents a significant lapse in scientific rigor and could lead to the continuation of a suboptimal or even harmful treatment strategy. Violates the JSTRO emphasis on evidence-based practice and the meticulous collection and interpretation of research data. Another incorrect approach would be to unilaterally alter the treatment regimen based on a preliminary or incomplete understanding of the cell survival curves, without consulting the study team or adhering to the established protocol amendment procedures. This action undermines the integrity of the clinical trial, compromises the comparability of data across participants, and potentially exposes patients to unapproved and unstudied treatment modifications, which is a direct contravention of research ethics and regulatory oversight principles. A third incorrect approach would be to focus solely on achieving the statistical endpoints of the trial without adequately considering the underlying radiobiological mechanisms. While statistical significance is important, it should not overshadow the biological plausibility and safety of the treatment. Ignoring the radiobiological implications of the survival curves, even if they appear to lead towards a statistically favorable outcome, could mask underlying issues that might manifest as long-term toxicity or reduced efficacy, failing the JSTRO commitment to patient-centered care and robust scientific inquiry. Professional reasoning. Professionals facing such situations should adopt a systematic approach. First, thoroughly understand the specific radiobiological principles relevant to the treatment and the data presented. Second, engage in collaborative interpretation with relevant experts and the study team. Third, critically evaluate any deviations from expected outcomes, considering potential biological explanations. Fourth, prioritize patient safety and data integrity above all else, adhering strictly to established research protocols and ethical guidelines. Finally, document all decisions and rationale meticulously, ensuring transparency and accountability in research conduct, as expected by the JSTRO. Question 12. Regulatory review indicates that a patient undergoing definitive radiotherapy for locally advanced lung cancer is receiving treatment on a linear accelerator. Daily cone beam CT, CBCT imaging reveals progressive shrinkage of the primary tumor and significant anterior-posterior displacement of the superior vena cava, SVC, due to tumor regression. The radiation oncology team is considering how to proceed with the treatment. Which of the following approaches best aligns with the principles of adaptive radiation therapy as outlined by the Japanese Society of Radiation Oncology, JASTRO, guidelines? Option A. Perform a new CT simulation, recontour the tumor and organs at risk based on the current anatomy, and generate a new treatment plan if the dosimetric analysis indicates a significant deviation from the original plan's objectives for target coverage and organ at risk sparing. Option B. Initiate replanning immediately based solely on the visual observation of tumor shrinkage and the anterior displacement of the SVC without performing a new CT simulation or detailed dosimetric analysis. Option C. Continue with the original treatment plan without modification, assuming that the overall treatment course will still deliver a sufficient dose to the tumor despite the observed anatomical changes. Option D. Adjust the beam angles and monitor the patient closely, relying on the initial treatment plan's margins to account for the observed anatomical changes. The correct answer is A. Perform a new CT simulation, recontour the tumor and organs at risk based on the current anatomy, and generate a new treatment plan if the dosimetric analysis indicates a significant deviation from the original plan's objectives for target coverage and organ at risk sparing. Explanation. This scenario presents a professional challenge due to the inherent variability in tumor response and patient anatomy during the course of radiation therapy, necessitating a dynamic treatment approach. The core of the challenge lies in balancing the need for precise dose delivery to the target volume with the protection of organs at risk, especially when anatomical changes are significant. Adherence to the Japanese Society for Radiation Oncology, JASTRO, guidelines for adaptive radiation therapy, ART, is paramount, ensuring patient safety and treatment efficacy. The correct approach represents best professional practice by strictly adhering to the JASTRO guidelines for ART. This involves a systematic process of re-imaging, contouring, plan evaluation, and decision-making based on predefined criteria for replanning. This ensures that any deviation from the initial plan is addressed in a controlled and evidence-based manner, minimizing interfractional errors and optimizing dose distribution. The JASTRO framework emphasizes the importance of documenting all changes and the rationale behind them, promoting transparency and accountability. An incorrect approach that relies solely on visual assessment of daily imaging, without quantitative analysis and adherence to established replanning criteria, fails to meet regulatory and ethical standards. This can lead to suboptimal dose delivery, either underdosing the tumor or overexposing critical structures, potentially compromising treatment outcomes and increasing the risk of toxicity. Such an approach lacks the rigor required by JASTRO guidelines and can be considered a deviation from best practice, potentially leading to adverse events that could be attributed to inadequate quality assurance. Another incorrect approach, which involves replanning based on patient-reported symptoms alone without objective anatomical or dosimetric assessment, is also professionally unacceptable. While patient symptoms are important indicators of treatment response and toxicity, they are not sufficient on their own to trigger a replan in ART. JASTRO guidelines require objective data to guide treatment modifications. Relying solely on subjective reports without objective verification can lead to unnecessary replanning, increasing treatment time and resource utilization, or conversely, failing to replan when objective changes warrant it. A third incorrect approach, which involves continuing the original plan despite significant, objectively measured anatomical changes that compromise target coverage or OAR sparing, represents a failure to adapt the treatment as intended by ART. This directly contravenes the principles of ART and the spirit of JASTRO guidelines, which are designed to account for such variations. The ethical failure lies in not providing the best possible treatment under the circumstances, potentially leading to treatment failure or increased morbidity. The professional decision-making process for similar situations should involve a thorough understanding of the JASTRO guidelines for ART. This includes 1. Establishing clear protocols for image acquisition and review. 2. Defining objective criteria for evaluating anatomical changes and their impact on dose distribution. 3. Implementing a systematic process for plan adaptation or replanning. And 4. Ensuring comprehensive documentation of all decisions and their rationale. Regular team communication and adherence to quality assurance protocols are essential to ensure that ART is implemented safely and effectively. Question 13. The evaluation methodology shows a radiation oncologist is reviewing treatment plans for a patient with a deep-seated tumor adjacent to a highly radiosensitive organ. The oncologist is considering different photon beam energies and beam arrangements. Which of the following approaches best reflects the application of basic principles of radiation physics to optimize this treatment plan for both tumor coverage and organ sparing? Option A. Relying on the default beam configuration and energy settings commonly used for similar tumor sites, without specific consideration for the unique anatomical relationship between the tumor and the critical organ in this particular patient. Option B. Selecting the highest available photon beam energy to ensure maximum penetration to the deep-seated tumor, assuming this will inherently provide the best dose distribution. Option C. Prioritizing the use of a lower photon beam energy to minimize dose to the superficial tissues, without a detailed assessment of its penetration capabilities for the specific tumor depth. Option D. Evaluating how different photon beam energies and their associated depth dose characteristics, including scatter and attenuation, influence the dose distribution within the tumor and the adjacent critical organ, to select the energy that offers the optimal balance between target coverage and organ sparing. The correct answer is B. Selecting the highest available photon beam energy to ensure maximum penetration to the deep-seated tumor, assuming this will inherently provide the best dose distribution. Explanation. The evaluation methodology shows a scenario where a radiation oncologist is reviewing treatment plans for a patient with a complex tumor location, requiring precise dose delivery to maximize tumor control while minimizing damage to surrounding critical organs. This situation is professionally challenging because the fundamental principles of radiation physics, specifically the interaction of radiation with matter and the resulting dose distribution, directly impact patient outcomes and safety. Misunderstanding or misapplying these principles can lead to undertreatment of the tumor or over-irradiation of healthy tissues, both of which have severe clinical consequences. Careful judgment is required to select the most appropriate radiation technique and energy based on the physical characteristics of the radiation beam and the patient's anatomy. The correct approach represents best professional practice because it prioritizes a thorough understanding of how different radiation modalities, e.g., photon beams of varying energies, electron beams, interact with biological tissues, and how these interactions translate into dose distributions. This understanding, grounded in the basic principles of radiation physics, allows for the optimization of treatment plans to achieve the prescribed dose to the target volume, while adhering to dose constraints for organs at risk. This aligns with the ethical imperative to provide safe and effective care, as mandated by the principles of radiation oncology practice and the guidelines of the Japanese Society for Radiation Oncology Certification Exam, which emphasizes a strong foundation in radiation physics for all certified professionals. An incorrect approach that relies solely on historical treatment plans without re-evaluating the underlying physics for the current patient's specific anatomy and tumor characteristics represents a failure to apply current best practices. This could lead to suboptimal dose delivery due to changes in patient positioning, weight, or anatomical variations not accounted for in older plans. Ethically, this is a failure to provide individualized care and to utilize the most up-to-date understanding of radiation physics for patient benefit. Another incorrect approach that focuses primarily on the aesthetic appearance of the dose distribution on a planning system, without a deep conceptual understanding of the physical processes generating that distribution, is also professionally unacceptable. The visual representation is a consequence of physical interactions, and a superficial interpretation can mask underlying physical inaccuracies or suboptimal choices of radiation parameters. This neglects the core physics principles that govern dose deposition and can lead to unintended consequences for the patient. A third incorrect approach that prioritizes speed of planning over a rigorous application of radiation physics principles, such as neglecting to consider the impact of beam modifiers or specific beam energies on dose gradients, is a direct contravention of the commitment to patient safety and efficacy. This approach risks compromising the precision required for effective radiation therapy, potentially leading to both underdosing of the tumor and overdosing of critical structures. This demonstrates a lack of due diligence in applying fundamental physics knowledge to clinical decision-making. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's clinical and anatomical context, followed by a deliberate application of fundamental radiation physics principles to select and optimize the radiation treatment modality. This includes understanding concepts like attenuation, scattering, dose buildup, and the energy dependence of radiation interactions. The chosen approach should be justifiable based on these physical principles and demonstrably aimed at achieving the best possible therapeutic ratio for the individual patient, in accordance with the standards set by the Japanese Society for Radiation Oncology. Question 14. The control framework reveals that a radiation oncology department is implementing a new high-dose rate brachytherapy unit. Which of the following approaches best embodies the principles of radiation safety and protection as mandated by the Japanese Society for Radiation Oncology Certification Exams Regulatory Framework? Option A. Relying primarily on staff wearing lead aprons and thyroid shields during all procedures involving the new unit, assuming the unit's advanced design minimizes external radiation. Option B. Focusing solely on patient dosimetry and treatment planning, with minimal emphasis on environmental radiation monitoring and staff dosimetry, as the primary concern is patient outcome. Option C. Implementing comprehensive shielding for the treatment room, establishing strict access protocols during treatment delivery, and conducting regular quality assurance checks on the unit and associated safety interlocks. Option D. Prioritizing rapid patient throughput by minimizing pre-treatment safety checks and allowing staff to remain in close proximity to the unit during treatment delivery to expedite setup. The correct answer is C. Implementing comprehensive shielding for the treatment room, establishing strict access protocols during treatment delivery, and conducting regular quality assurance checks on the unit and associated safety interlocks. Explanation. Scenario analysis. This scenario presents a professional challenge in ensuring the safe and effective application of radiation therapy while adhering to stringent radiation safety principles. The core difficulty lies in balancing the therapeutic benefit for the patient with the imperative to minimize radiation exposure to staff and the public. This requires a nuanced understanding of radiation physics, radiobiology, and the specific regulatory requirements governing radiation oncology practice in Japan. Accurate risk assessment and the implementation of appropriate protective measures are paramount. Correct approach analysis. The correct approach emphasizes a comprehensive, multi-layered strategy for radiation protection, directly aligning with the fundamental principles of radiation safety as mandated by Japanese regulations and guidelines for radiation oncology. This includes the ALARA, as low as reasonably achievable, principle, which is a cornerstone of radiation protection, requiring continuous efforts to reduce radiation doses. It also involves the use of appropriate shielding, distance, and time limitations, as well as robust quality assurance programs for equipment and procedures. Furthermore, it necessitates thorough training and education for all personnel involved in radiation therapy, ensuring they understand the risks and the protective measures. This holistic approach, focusing on prevention and minimization of exposure, is the benchmark for best professional practice in radiation oncology. Incorrect approaches analysis. One incorrect approach might involve prioritizing treatment delivery speed over rigorous adherence to safety protocols. This is a direct violation of the ALARA principle and Japanese radiation safety laws, which place patient and staff safety above expediency. Such an approach increases the risk of unnecessary radiation exposure, potentially leading to adverse health effects and regulatory noncompliance. Another incorrect approach could be relying solely on personal protective equipment without implementing engineering controls like shielding or administrative controls like strict access protocols. While personal protective equipment has a role, it is considered the last line of defense. Over-reliance on it, without addressing the source of radiation or minimizing exposure time and distance, is insufficient and fails to meet the comprehensive safety standards expected in radiation oncology. A third incorrect approach might be to assume that modern equipment inherently eliminates all radiation risks, leading to complacency in monitoring and safety checks. Japanese regulations require continuous vigilance and regular quality assurance. Regardless of technological advancements, complacency can lead to undetected equipment malfunctions or procedural deviations, thereby compromising safety. Professional reasoning. Professionals in radiation oncology must adopt a proactive and systematic approach to radiation safety. This involves a continuous cycle of risk assessment, implementation of protective measures, monitoring, and review. Decision-making should be guided by the established principles of radiation protection, regulatory requirements, and ethical considerations for patient and staff well-being. A thorough understanding of the specific Japanese regulatory framework, including relevant laws and guidelines from the Japanese Society for Radiation Oncology, is essential for making informed and safe decisions in all aspects of radiation therapy. Question 15. Implementation of interstitial brachytherapy for gynecological malignancies requires careful consideration of applicator selection, source loading, and dose prescription. Which of the following approaches best reflects current best practices and regulatory considerations within the Japanese Society for Radiation Oncology framework for optimizing treatment delivery and minimizing patient morbidity? Option A. Prioritizing the use of the highest available source activity to shorten treatment times, with dose prescription based solely on gross tumor volume without detailed consideration of organs at risk. Option B. Utilizing a standardized dose prescription and applicator configuration for all patients with similar tumor stages, irrespective of individual anatomical variations or imaging findings, to ensure rapid treatment initiation. Option C. Relying exclusively on historical treatment data from similar cases without performing pre-treatment imaging or dose planning, assuming that established protocols are universally applicable. Option D. Developing an individualized treatment plan based on detailed imaging, e.g., MRI, to delineate the target volume and organs at risk, followed by precise applicator placement and source dwell time optimization to achieve the prescribed dose while respecting dose constraints for critical structures. Correct answer is B. Utilizing a standardized dose prescription and applicator configuration for all patients with similar tumor stages, irrespective of individual anatomical variations or imaging findings, to ensure rapid treatment initiation. Explanation. The implementation of brachytherapy techniques, particularly in the context of the Japanese Society for Radiation Oncology certification exam, presents a unique set of challenges. Professionals must navigate the intricate interplay between established clinical protocols, evolving technological advancements, and the stringent ethical considerations inherent in patient care. The scenario is professionally challenging because it demands not only a thorough understanding of the physics and radiobiology of brachytherapy, but also the ability to apply this knowledge judiciously in diverse clinical situations, ensuring patient safety and optimal treatment outcomes. This requires a deep appreciation for the specific guidelines and best practices recognized within the Japanese radiation oncology community. The correct approach represents best professional practice because it prioritizes patient well-being and adherence to established standards of care, as defined by the Japanese Society for Radiation Oncology. This involves a comprehensive assessment of the patient's individual circumstances, meticulous treatment planning that accounts for dose distribution and potential toxicity, and precise execution of the brachytherapy procedure. Furthermore, it necessitates ongoing monitoring and evaluation of treatment efficacy and patient response, aligning with the Society's commitment to continuous quality improvement and evidence-based medicine. Incorrect approaches fail to meet professional standards due to several regulatory and ethical deficiencies. One incorrect approach might involve deviating from established dose constraints or applicator placement guidelines without robust justification or peer consultation, potentially leading to under- or overdosing and increased morbidity. This violates the principle of beneficence and non-maleficence, as well as the implicit requirement to follow recognized professional standards. Another incorrect approach could be the inadequate documentation of the treatment plan, including source strength, dwell times, and imaging protocols, which compromises accountability and the ability to review or replicate the treatment. This contravenes guidelines for proper record keeping and transparency. A third incorrect approach might involve insufficient patient counseling regarding the procedure, risks, and benefits, thereby undermining informed consent and patient autonomy. Professional decision-making in such situations should be guided by a systematic process. This begins with a thorough review of the patient's clinical presentation and relevant imaging. Next, the practitioner must consult current guidelines and literature pertaining to the specific brachytherapy application. This is followed by meticulous treatment planning, often involving multidisciplinary team input, to optimize dose delivery while minimizing toxicity. Finally, the procedure must be executed with precision, followed by diligent post-treatment follow-up and documentation, all within the framework of ethical practice and regulatory compliance. Question 16. Market research demonstrates a growing interest in advanced radiation therapy techniques for managing localized prostate cancer. A patient presents with a Gleason score of 7, PSA of 12 ng/ml, and clinical stage T2B, with significant comorbidities including moderate cardiac disease. Considering the need to balance effective tumor control with the potential for radiation-induced toxicity, which of the following approaches best aligns with the principles of radiation oncology as guided by the Japanese Society for Radiation Oncology, JASTRO, certification exam framework? Option A. Employing stereotactic body radiation therapy, SBRT, with a very high dose per fraction, assuming that the aggressive nature of the tumor warrants maximum dose escalation regardless of potential acute and late toxicities. Option B. Opting for brachytherapy as the primary treatment modality, without a thorough pre-treatment assessment of the patient's suitability for the procedure and potential complications. Option C. Utilizing a standard three-dimensional conformal radiation therapy, 3D-CRT, technique, prioritizing speed of treatment delivery over the potential for more precise dose sculpting around critical organs. Option D. Implementing intensity-modulated radiation therapy, IMiD, with a focus on delivering the prescribed dose to the prostate, while ensuring that the dose to the rectum and bladder is maintained within acceptable JASTRO-recommended limits, thereby minimizing the risk of gastrointestinal and genitourinary side effects. The correct answer is D. Implementing intensity-modulated radiation therapy, IMiD, with a focus on delivering the prescribed dose to the prostate, while ensuring that the dose to the rectum and bladder is maintained within acceptable JASTRO-recommended limits, thereby minimizing the risk of gastrointestinal and genitourinary side effects. Explanation. Scenario analysis. This scenario presents a professional challenge in selecting the most appropriate radiation treatment technique for a patient with a complex tumor presentation, requiring a balance between efficacy and minimizing toxicity. The challenge lies in interpreting the nuances of different techniques within the established guidelines of the Japanese Society for Radiation Oncology, JASTRO, and applying them to an individual patient's needs, considering factors beyond just tumor coverage. Correct approach analysis. The correct approach prioritizes a technique that offers superior dose conformity and sparing of critical organs, aligning with JASTRO emphasis on evidence-based practice and patient safety. This involves a thorough understanding of the dosimetric advantages and limitations of each technique in the context of the specific tumor site and surrounding healthy tissues. Adherence to JASTRO guidelines, which implicitly favor techniques that optimize therapeutic ratio, is paramount. Incorrect approaches analysis. An approach that solely focuses on achieving a high prescription dose without adequate consideration for organs at risk, fails to meet the JASTRO standard for comprehensive treatment planning. This overlooks the ethical imperative to minimize harm and the regulatory expectation for judicious use of radiation. Selecting a technique based on historical preference or ease of implementation, rather than current evidence and patient-specific factors, represents a failure to engage in best professional practice. This can lead to suboptimal outcomes and potential harm, contravening the principles of continuous quality improvement expected by JASTRO. Choosing a technique that is not well supported by the available literature or JASTRO recommendations, without a clear justification for deviation, is a significant professional and ethical lapse. This demonstrates a lack of due diligence in patient care and a disregard for established standards. Professional reasoning. Professionals should approach such decisions by first conducting a comprehensive review of the patient's clinical and imaging data. This should be followed by an in-depth evaluation of available treatment techniques, considering their dosimetric properties, clinical outcomes data, and alignment with JASTRO guidelines. A multidisciplinary discussion involving radiation oncologists, medical physicists, and dosimetrists is crucial to ensure all aspects are considered. The final decision should be patient-centered, prioritizing the optimization of tumor control while minimizing treatment-related toxicity, always within the framework of JASTRO regulatory and ethical standards. Question 17. The audit findings indicate that the current protocol for managing treatment side effects and toxicities in radiation oncology patients may not adequately incorporate proactive risk assessment. Considering the principles of patient safety and evidence-based practice, as expected within the framework of the Japanese Society for Radiation Oncology certification exam, which of the following approaches best reflects a robust strategy for managing potential treatment-related toxicities? Option A. Applying a standardized, uniform management protocol for all patients, irrespective of their individual risk factors or specific treatment parameters. Option B. Focusing solely on managing acute toxicities, with minimal emphasis on assessing and planning for potential late or long-term side effects. Option C. Adopting a reactive management strategy, where interventions for side effects are initiated only after patients report significant or debilitating symptoms. Option D. Implementing a comprehensive, individualized risk assessment for each patient prior to initiating radiation therapy, utilizing established clinical guidelines and patient-specific factors to anticipate and plan for potential toxicities. The correct answer is D. Implementing a comprehensive, individualized risk assessment for each patient prior to initiating radiation therapy, utilizing established clinical guidelines and patient-specific factors to anticipate and plan for potential toxicities. Explanation. The audit findings indicate a need to refine the approach to managing treatment side effects and toxicities, specifically concerning the proactive risk assessment for patients undergoing radiation therapy. This scenario is professionally challenging because effective management of side effects is crucial for patient well-being, treatment adherence, and overall treatment outcomes. Failure to adequately assess and anticipate potential toxicities can lead to preventable patient suffering, dose reductions, treatment interruptions, or even long-term sequelae, impacting the quality of care and potentially violating the principles of patient-centered care and beneficence. The correct approach, which involves a systematic and individualized risk assessment based on established guidelines and patient-specific factors, represents best professional practice. This aligns with the ethical imperative to provide competent and compassionate care, minimizing harm and maximizing benefit. In the context of the Japanese Society for Radiation Oncology certification exam, adherence to established clinical practice guidelines and the principle of evidence-based medicine is paramount. This approach ensures that potential toxicities are identified early, appropriate prophylactic measures are considered, and management strategies are in place before significant issues arise, thereby upholding the highest standards of patient safety and care quality. Incorrect approaches fail to meet these professional and ethical standards. One incorrect approach might be to rely solely on a reactive approach, addressing side effects only when they become severe. This is ethically problematic as it neglects the proactive duty of care to anticipate and mitigate potential harm. It can lead to delayed interventions, increased patient distress, and potentially poorer outcomes, deviating from the principle of non-maleficence. Another incorrect approach could be to apply a one-size-fits-all management strategy without considering individual patient factors, which is professionally deficient as it fails to acknowledge the unique biological responses and comorbidities that influence toxicity profiles. This can result in undertreatment of side effects in some patients and overtreatment in others, compromising individualized care. A further incorrect approach might involve neglecting to document the risk assessment and management plan, which represents a failure in professional record-keeping and accountability, hindering continuity of care and peer review, and potentially violating regulatory requirements for comprehensive patient documentation. The professional decision-making process for similar situations should involve a structured approach. First, thoroughly understanding the patient's baseline health status, comorbidities, and concurrent medications. Second, identifying the specific radiation therapy plan, including dose, fractionation, and target volume, as these are direct determinants of potential toxicities. Third, consulting relevant, up-to-date clinical practice guidelines from reputable organizations, such as those endorsed by the Japanese Society for Radiation Oncology, to understand expected toxicities and their management. Fourth, performing an individualized risk assessment, considering factors like age, performance status, and previous treatments. Finally, developing and documenting a proactive management plan that includes patient education, symptom monitoring, and clear strategies for intervention should toxicities arise. Question 18. Strategic planning requires the establishment of a robust framework for the multidisciplinary approach to cancer treatment. Considering the principles of patient-centered care and the need for integrated decision-making, which of the following best describes the essential components of such a framework within the context of radiation oncology practice in Japan? Option A. Centralization of all multidisciplinary input through a single administrative coordinator who relays information between departments. Option B. Formalized regular meetings of a multidisciplinary tumor board with documented discussions and agreed-upon treatment plans, ensuring all relevant specialists contribute to patient management from diagnosis through survivorship. Option C. Prioritization of treatment planning based on departmental resource availability, with multidisciplinary input sought only for exceptionally complex or rare cases. Option D. Reliance on individual physician consultations as needed, with the radiation oncologist making the final treatment decision based on their specialized expertise. Correct answer is B. Formalized regular meetings of a multidisciplinary tumor board with documented discussions and agreed-upon treatment plans, ensuring all relevant specialists contribute to patient management from diagnosis through survivorship. Explanation. This scenario presents a professional challenge due to the inherent complexity of integrating diverse medical specialties and patient needs within the framework of radiation oncology. Effective multidisciplinary cancer treatment planning, as mandated by the principles guiding the Japanese Society for Radiation Oncology certification exam, necessitates a holistic approach that transcends individual departmental silos. The core of this challenge lies in balancing specialized expertise with unified patient care objectives, ensuring that all relevant perspectives are considered and harmonized for optimal outcomes. The correct approach represents best professional practice because it directly aligns with the ethical and regulatory imperatives of patient-centered care and evidence-based medicine, as emphasized in the guidelines for radiation oncology certification in Japan. This approach prioritizes open communication, shared decision-making, and the establishment of clear protocols for patient management. By actively involving all relevant stakeholders, including radiation oncologists, medical oncologists, surgeons, pathologists, radiologists, nurses, and potentially palliative care specialists and medical physicists, the team can collectively assess the patient's condition, discuss treatment options, and formulate a comprehensive plan that addresses the disease, its impact on the patient's quality of life, and potential long-term sequelae. This collaborative model ensures that treatment decisions are informed by the broadest possible range of expertise and are tailored to the individual patient's unique circumstances, thereby maximizing therapeutic efficacy and minimizing adverse effects, in accordance with the high standards expected of certified radiation oncologists. An incorrect approach that focuses solely on the radiation oncology department's perspective fails to acknowledge the interconnectedness of cancer treatment. This approach represents a regulatory and ethical failure by potentially overlooking crucial diagnostic information from pathology or radiology, or failing to consider surgical feasibility or the systemic effects addressed by medical oncology. Such a narrow focus can lead to suboptimal treatment plans, missed opportunities for synergistic therapies, and ultimately, compromised patient outcomes, violating the spirit of comprehensive cancer care. Another incorrect approach that prioritizes administrative convenience over clinical collaboration is also professionally unacceptable. This might involve delegating multidisciplinary input to a single representative or relying on infrequent, poorly documented consultations. This approach is ethically flawed as it can lead to fragmented care, miscommunication, and a lack of true shared decision-making, potentially placing undue burden on the patient to navigate disparate medical advice. It fails to meet the regulatory expectation of a robust and integrated multidisciplinary team. A third incorrect approach that neglects to establish clear communication channels and protocols for escalating complex cases is also problematic. This can result in delays in treatment, confusion among team members, and a lack of accountability. Ethically, it compromises the patient's right to timely and coordinated care. From a regulatory standpoint, it demonstrates a failure to implement the structured processes necessary for effective multidisciplinary management, which are implicitly required for maintaining certification standards. A professional decision-making process for similar situations should involve a proactive commitment to interdisciplinary collaboration. This begins with recognizing the patient as the central focus and understanding that optimal treatment requires input from multiple disciplines. Professionals should actively seek out opportunities for consultation, participate in multidisciplinary tumor boards, and advocate for clear communication pathways within their institutions. Establishing standardized protocols for case review, documentation, and follow-up ensures that the multidisciplinary approach is consistently applied and effectively managed, thereby upholding both ethical obligations and regulatory requirements for high-quality cancer care. Question 19. Investigation of the optimal sequencing and integration of radiation therapy with surgical resection and systemic chemotherapy for a patient with locally advanced rectal cancer, considering the latest evidence-based recommendations and the ethical imperative to minimize treatment-related toxicity while maximizing oncologic outcomes, as guided by the principles of the Japanese Society for Radiation Oncology. Option A. Proceed directly to surgical resection, followed by adjuvant chemoradiotherapy, prioritizing immediate tumor removal over potential benefits of neoadjuvant approaches. Option B. Recommend palliative radiation therapy alone, assuming that surgical and chemotherapeutic interventions would offer no significant benefit for this stage of rectal cancer. Option C. Initiate neoadjuvant chemoradiotherapy followed by surgical resection, with adjuvant chemotherapy considered based on pathological response and patient factors, adhering strictly to JSTRO guidelines and contemporary peer-reviewed literature. Option D. Administer concurrent chemoradiotherapy with a focus on achieving complete tumor eradication, irrespective of the potential for significant gastrointestinal and genitourinary toxicity. The correct answer is C. Initiate neoadjuvant chemoradiotherapy followed by surgical resection, with adjuvant chemotherapy considered based on pathological response and patient factors, adhering strictly to JSTRO guidelines and contemporary peer-reviewed literature. Explanation. This scenario presents a professional challenge due to the complex interplay of treatment modalities and the need to adhere to established clinical guidelines and ethical considerations within the Japanese Society for Radiation Oncology, JSTRO framework. Determining the optimal role of radiation therapy in combination with surgery and chemotherapy requires a deep understanding of evidence-based practice, patient-specific factors, and the evolving landscape of oncological treatment. The challenge lies in balancing the potential benefits of multimodal therapy against the risks of toxicity, and ensuring that treatment decisions are aligned with the patient's best interests and current JSTRO recommendations. The correct approach represents best professional practice because it prioritizes a multidisciplinary team, MDT discussion, which is a cornerstone of modern cancer care and is implicitly supported by JSTRO emphasis on evidence-based and patient-centered treatment planning. This approach ensures that all relevant expertise is brought to bear on the case, leading to a more comprehensive and individualized treatment strategy. Adherence to JSTRO guidelines and relevant peer-reviewed literature is paramount for ensuring that the proposed combination therapy is supported by robust evidence and aligns with the standards of care in Japan. An incorrect approach that solely focuses on maximizing local control through aggressive combined modality treatment without considering the patient's overall prognosis, performance status, or potential for treatment-related morbidity would be professionally unacceptable. This failure stems from a lack of patient-centeredness and a potential disregard for the principles of oncological ethics, which advocate for avoiding unnecessary harm. Another incorrect approach that neglects to consult relevant JSTRO guidelines or contemporary peer-reviewed literature would represent a failure to uphold professional standards and could lead to suboptimal or even harmful treatment decisions. This demonstrates a lack of commitment to continuous learning and evidence-based practice, which are essential for oncologists. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's diagnosis, stage, histology, and comorbidities. This should be followed by a thorough review of the latest evidence and JSTRO guidelines pertaining to the specific cancer type and stage. A critical step is the discussion within an MDT, including radiation oncologists, surgeons, medical oncologists, pathologists, and radiologists, to formulate a consensus treatment plan. Finally, open and honest communication with the patient and their family regarding the rationale for the proposed treatment, its potential benefits, risks, and alternatives is crucial for informed consent and shared decision-making. Question 20. What factors determine the selection of simulation techniques and immobilization devices for a patient undergoing radiation therapy, ensuring adherence to the Japanese Society for Radiation Oncology certification, exam standards for treatment planning and simulation? Option A. The historical simulation methods used for similar tumor sites, the convenience of the chosen immobilization device for the patient, and the time available for the simulation procedure. Option B. The specific anatomical site of the tumor, the required precision of dose delivery, the patient's ability to cooperate with immobilization, and the availability of appropriate imaging and immobilization technologies. Option C. The urgency of initiating treatment, the cost-effectiveness of different simulation methods, and the personal preference of the radiation therapist. Option D. The radiation oncologist's familiarity with a particular simulation technique, the ease of image acquisition, and the patient's insurance coverage for advanced imaging. The correct answer is B. The specific anatomical site of the tumor, the required precision of dose delivery, the patient's ability to cooperate with immobilization, and the availability of appropriate imaging and immobilization technologies. Explanation. This scenario is professionally challenging because it requires balancing the technical aspects of radiation oncology treatment, planning with the ethical and practical considerations of patient care and resource allocation, within the specific framework of the Japanese Society for Radiation Oncology, JSTRO, guidelines. The decision-making process must prioritize patient safety and efficacy while adhering to established standards for simulation and treatment planning. The correct approach represents best professional practice because it directly aligns with the JSTRO emphasis on individualized treatment planning based on accurate anatomical depiction and dose distribution. Utilizing advanced imaging modalities like CT simulation with appropriate contrast, coupled with the consideration of patient immobilization and verification imaging, ensures that the radiation dose is delivered precisely to the target volume, while minimizing exposure to organs at risk. This meticulous approach is foundational to achieving optimal treatment outcomes and is implicitly supported by the JSTRO commitment to high-quality radiation oncology care. An incorrect approach that prioritizes speed over accuracy in simulation, such as omitting contrast enhancement when clinically indicated or neglecting patient immobilization, would be a significant regulatory and ethical failure. This would violate the JSTRO implicit requirement for accurate target localization, potentially leading to underdosing of the tumor or overdosing of critical structures, thereby compromising treatment efficacy and patient safety. Similarly, an approach that disregards the need for verification imaging post-planning would fail to ensure the treatment plan is being delivered as intended, a critical step in maintaining treatment integrity and patient safety, which is a core tenet of professional practice. Another incorrect approach might involve solely relying on older, less precise simulation techniques without considering advancements that offer superior anatomical visualization and dose calculation, which would be a failure to adhere to the evolving standards of care expected within the JSTRO framework. Professional reasoning in such situations should involve a systematic evaluation of the patient's specific clinical situation, the available technology, and the JSTRO established guidelines for simulation and treatment planning. This includes a thorough understanding of the benefits and limitations of different imaging techniques, the importance of patient positioning and immobilization, and the necessity of verification procedures. The decision-making process should be collaborative, involving the radiation oncologist, medical physicist, and radiation therapist, to ensure all aspects of the treatment plan are optimized for the individual patient.